myself, I am Dr. Preeti Gehlot. I am professor in Department of Anesthesiology at PGIMS Rohtak. And today I'll be speaking about introduction and approach to acute respiratory failure, a case-based discussion. The same topic would be discussed in details as type 1 and type 2 respiratory failure later also. So I'll be just speaking about the approach and introduction as a whole. And first of all, I thank the organizers for inviting me over for this program. Thank you so much. So the objectives for my talk would be that after this talk, one should be able to recognize the clinical signs and symptoms of acute respiratory failure. One should be able to define and classify acute respiratory failure, describe the various etiologies, describe the pathophysiology and management of hypoxemic as well as hypercapnic respiratory failure, and should be able to discuss the role of therapy in the treatment. It will be a case-based discussion. So coming to acute respiratory failure, how do we define it? So it is defined as the loss of ability to ventilate adequately. In simple terms, when a patient comes, basically the patient is not able to ventilate adequately and that person is not getting sufficient oxygen to the systemic organs. That is why the breathing issue or the dyspnea. So this can also be said that the pulmonary system is no longer able to meet the metabolic demands of the body with respect to oxygenation of the blood or CO2 elimination. Ventilation includes both oxygenation and ventilation. So now coming to the basic classification. Most important are type 1 and type 2, but in total there are 4 types. So type 1 is the hypoxemic failure, wherein PO2 is less than 60 millimeter of mmHg on room air, and it's usually seen in patients with acute pulmonary edema or acute lung injury. So here the main issue is with oxygenation. The person is able to handle CO2. Now coming to type 2 or hypercapnic ventilatory failure, PCO2 of more than 45 mmHg. This we're talking on an arterial blood gas analysis, on an ABG, when we do an ABG. So, if a person is already not a chronic retainer, and the most common cause is respiratory pump failure. Type 3 is generally perioperative, which is a subset of type 1 only. However, it may proceed to become type 2 also. And type 4 is because of shock, which is secondary to cardiovascular instability. So out of these, first and second are the most common. However, we do meet a lot of patients of type 3 and 4 in our ICUs. So we must know and recognize them as well. Coming to etiologies. So, coming to etiologies, primary etiology either will be within the lung or outside of the lung. So it can be extrathoracic or within the thorax. We have to understand that. And causes may be multifactorial. So this is just a gist of the overall complete pathologies, the areas that can be affected, like upper airways, some kind of obstruction, mass, vocal cord paralysis, vocal cord mass. Then lower airways like bronchospasm, CHF, any kind of infections affecting lung parenchymal, infection, interstitial lung diseases, chest wall conditions like kyphoscoliosis, obesity, CNS, wherein the respiratory drive is affected. Example, CNS infections, metabolic encephalopathy, and central alveolar hypoventilation syndrome, etc. Then coming to spinal cord, trauma and transverse myelitis at certain levels can affect respiration too. Neuromuscular system, like polio, tetanus, Guillain-Barré syndrome, we so often meet in ICUs. Critical care or steroid myopathy also. And lastly, cardiovascular system, because heart and lung, they are both in interaction all the time. So now coming to introduction to type 1 respiratory failure. So basically, it is a low FiO2. What are the reasons? What is the pathophysiology? How does a person lands up in type 1 failure? So one of the reasons can be low FiO2 intake. So why should there be low FiO2? Example, when a person goes to high altitude. Everybody knows when we go to Leh Ladakh, there's a chance that we might have hypoxia. So that is because of low FiO2. Then another very common thing In an already existing patient in ICU, if a person suddenly desaturates, we must always look at our connections, our oxygen connections. There may be disconnections or interruptions to the oxygen supply causing low FiO2. Then VQ mismatch and shunt. Now these two are very important terms, especially for the postgraduate students. Basically, VQ mismatch basically means ventilation perfusion mismatch. So in one condition, VQ mismatch, if ventilation is adequate and there is no perfusion, it is called as shunt. And how do we know whether ventilation is affected or the perfusion is affected? One very easy way is to differentiate, is to check response to oxygen therapy. You give oxygen, VQ mismatch responds very rapidly to oxygen, whereas shunt is very oxygen insensitive, because you cannot increase blood supply by increasing oxygen supply. So therapy for shunt, in case when you give oxygen and the hypoxia doesn't improve and you're thinking of shunt, so how do we improve the shunt now? To improve the shunt, we have to reopen or recruit the collapsed alveoli that might have collapsed, the alveoli which are getting the blood supply but they are not open. Then it can be preventing de-recruitment. So we can have certain, we can apply a PEEP, we can have recruitment maneuvers, then diminishing lung water in case there is pulmonary edema, etc. Improving pulmonary hypoxic vasoconstriction. So you have to take care of the CO2, you have to take care of the acidosis, to take care of the pulmonary vasoconstriction. So examples of VQ mismatch would be cardiogenic pulmonary edema, non-cardiogenic pulmonary edema, most common ARDS, the pneumonias, atelectasis, and last would be diffusion abnormality. And remember, CO2 diffuses very rapidly across the membranes. It is the oxygen which is affected in the diffusion capacity, not the CO2. So that is why it generally comes under respiratory type 1 failure. Now, what are the most common therapies? This is just an overview, not targeted therapy. So in case somebody has type 1 respiratory failure, of course, oxygen is the mainstay of the therapy. PEEP, like to open up the alveoli. Diuresis in case of excessive water in the lungs. Prone position, permissive hypercapnia, we can allow it. Like in ARDS we do. Inverse ratio ventilation, nitric oxide, and ECMO, ECOR, etc. Coming to type 2, which is ventilatory failure or hypercapnic respiratory failure. Whenever we say the word ventilation, remember, ventilation involves both intake of oxygen and removal of carbon dioxide. That is why type 2 failure is called as a ventilatory failure, not as a hypoxemic failure. So the cause of hypercapnia here is often independent of hypoxemia. Basically, there may or may not be hypoxemia in these patients. So what are the common reasons? The two most common reasons are increased CO2 production and decreased alveolar ventilation. So obviously CO2 would be increased either when CO2 cannot come out of the body or too much carbon dioxide is being produced inside the body. So increased CO2 production would be whenever there is a high metabolic demand like fever, sepsis, burns, overfeeding and certain syndromes. However, decreased alveolar ventilation is way more common as compared to these conditions like decreased respiratory rate, decreased tidal volume or increased dead space. Now why should they be? So let's look into the pathophysiology a little more. Causes of decreased alveolar ventilation. So there will be two kind of situations where a patient either can't breathe or a patient won't breathe. So either a patient cannot breathe or a patient won't breathe. What's the difference? So number one is decreased CNS drive. Basically from the respiratory center there is decreased respiratory drive. So what happens? It happens in case of CNS lesions, tumors, certain drug overdoses, post anesthesia it can happen where the body is unable to sense the increase, the brain is unable to sense the increased PaCO2 and the patient won't breathe. So won't breathe means that everything is alright within the lungs but the patient still won't breathe because the brain is not giving the signal. Coming to neuromuscular issues wherein the patient cannot breathe because we need our muscles to breathe. So here unable to neurologically signal the muscles of respiration or significant intrinsic respiratory muscle weakness. Both the reasons can be there. Then third is increased work of breathing. Again here the patient relatively cannot breathe in spite of wanting to breathe. So like asthma, COPD, respiratory muscle fatigue because of high respiratory rates. And lastly, increased physiological dead space may happen, which can cause increased CO2. For example, blood flow to some alveoli is significantly diminished and CO2 is not transferred across the alveolar membrane. Example, pulmonary embolics. We all know that there is a sudden rise of end-tidal CO2 and hypovolemia, wherein the patient does not have enough blood supply. So, the CO2, in spite of being produced, cannot come across the membranes. Now, how do we evaluate hypercapnia in these situations? So, this is just a brief gist of it. So, assessment of patient's work of breathing is very important, because work of breathing is what is making the patient tired and unable to breathe. So, patient would have accessory respiratory muscle use, indrawing, retractions, abdominal paradox. Then negative inspiratory force. So, we can measure that. If the negative inspiratory force is less than minus 20 to 25 centimeter of water, that means patient does not have adequate muscle strength and patient will not be able to sustain spontaneous respiration. P.1 max, that is degree of pressure drop during the first 100 milliseconds of a patient initiated breath. If we measure that degree of pressure drop, then we can estimate the patient's respiratory drive, which comes from the brain. So here, one easy way to say won't breathe versus can't breathe, how to differentiate is that in central causes, there will be low P.0.1, that is there will be low drive. The patient will not be able to have a respiratory pressure drop during the first 100 milliseconds with normal negative inspiratory force because the lungs are working well. Remember, the negative inspiratory force comes from the lungs. And in case of neuromuscular weakness, it will be opposite, where patients will have low negative inspiratory force because the problem is with the lungs now. And the respiratory drive or the pressure drop within the first 100 milliseconds would be normal. Now type 3 or perioperative respiratory failure, like I said initially, it is a subset of type 1 and it is also called as post-operative respiratory failure. So causes generally are decreased functional residual capacity, because whenever a person is in supine position or various other positions like Trendelenburg, etc. during surgeries, the lower lobes are affected the most. They undergo atelectasis. And it is more common in patients who undergo surgeries who in supine position, in obese patients, patients with ascites or intra-abdominal increased pressures, obviously general anesthesia, upper abdominal incisions, because that would cause more pain and hamper deep inspiratory efforts post-operative period, and airway secretions. So, what do we do about it? So in brief, if a person is having type 3 respiratory failure, so you can turn the patient every 1 to 2 hours into a different position to take care of all the lung areas, chest physiotherapy, incentive spirometry, treat incisional pain. It is very important because pain is something, especially for upper abdominal incisions, which will hamper deep inspiratory efforts and coughing. So ventilated 45 degrees upright, the patient should be upright in the bed, and re-expansion of lobar collapse and avoid overhydration so that the person does not land up into wet lungs. Now type 4 or shock induced respiratory failure would be hypoperfusion leading so no problem. It's okay. It's all right. So hypoperfusion can lead to respiratory failure in type 4. So basically here what happens is that ventilatory therapy, what happens is that whatever blood is there in the body in case of shock, we all know that that blood is targeted towards the important organs like brain, heart, to maintain the basic life functions, and it is taken away from rest of the organs. So here what happens is that respiratory muscles also suffer. They do not get enough supply and the patient is not able to breathe well. So we provide ventilatory therapy here as a bridge therapy to minimize the steal of the limited cardiac output by the overworking respiratory muscles. So we give rest to the muscles while we take care of the shock part, and once the shock is reversed, the patient will be obviously automatically able to breathe again. So it can happen in any kind of shock like cardiogenic, hypovolemic or septic shocks. So just 2-3 brief cases here to discuss so that you get an overview of what we just discussed. So case 1, suppose there's a 55-year-old male, a known hypertensive who comes to emergency. He's presented with a dry cough of 5 days, chest pain since last 2 days now, and sweating and breathlessness with 1 day with cold extremities. He feels better on sitting and cannot breathe while lying down. On examination, heart rate is 110, BP is 90 mm systolic, and he has cyanosis, peripheral cyanosis, and his SpO2 is 87% on room air on pulse oximetry. So we do an ABG, his pH is 7.35, which is normal. PO2 is 60 on an inspired oxygen of 0.6. That is 60% oxygen is being substituted, and still the PO2 is 60. And PaCO2 30 and bicarbs are 20 millicurrent. Chest X-ray was done for him, which looks like this. So what do you think it is? What kind of respiratory failure it is? Can somebody answer? It will be good if we have a discussion here, because this is for us to understand. So it is look at the APG again. The PO2 is 60.